So, welcome all of you to today's webinar. We had different titles for this webinar. One is You're Not Crazy, It's Your Hormones. And also is Technology is My Best Friend, because technology is always a fun thing for me. But why you don't feel you like yourself after 40 and what actually works. I'm Dr. Diana Hoppe. I'm going to introduce myself in the next slide, but I really want to thank everyone for taking the time and being here with me for this presentation. So let's go to the next slide. So who am I? I am a board certified OBGYN with over 30 years experience. I have some of my patients here on the call with me, so it's wonderful to see all of you here. Nancy, Laura, Jasna, thanks for joining me, and all others that are coming. Thank you for being here. I love to do work on hormones and weight loss. I'm an award-winning author. I wrote a book about women and sex drive. It's called Healthy Sex Drive, Healthy You, What Your Libido Reveals About Your Life. And that was a really fun book to write because I did clinical trials on that. I love helping women with perimenopause and menopause, their struggles, their challenges. And let me move this little bar out of the way. I'm also a stage 1 breast cancer survivor. So when people with breast cancer come and ask me, can I take hormone therapy? I tell them my story. I go over the pros and cons. And it does not mean necessarily you cannot be on hormones. It actually means that we have to go over what are the risks and benefits and then make the best decision for you. One of my favorite quotes is, "You are not broken, your body is asking for support." And I do believe that to be true for a lot of things in life, just specifically with hormone therapy. I've been featured on different magazines, contributing to different shows, TV, radio, etc. And this is just a few of the things that I've been on, just to give you some background about where I've been over the last 30 years. I also am proud to say I have lots of wonderful reviews on Google. I love seeing new patients. So if you're a patient of mine and know someone who needs help, please refer them my way. This is my passion, but I feel like it's really my dream to help women through this time and really flourish so that they feel their best and optimize their health. So I want to make this a little interactive, so it's not going to be just a unilateral conversation. Which one of these three resonates with you right now? And it could be number one, something feels off, but I can't explain it. Two, I don't feel like myself anymore. Or three, my labs are normal, but I still feel terrible. So if you want to put that in the chat box, you can put in your response, but you might be all of these, and it might just be that you don't feel like yourself anymore. I hear a lot of those comments from people. And so I don't know if I can see the chat box, but I will try to see if I can see it. Here we go. All right. So number one, so thank you, Jesse, for putting yours in there. Jasna, all three. Yeah. So basically, we all can have variations of how we're feeling about this right now. So a lot of my patients say, my labs are normal, but I still feel terrible. And the doctor won't do anything about it because the labs are, quote, normal, right? But be honest, I think all of us can be feeling like something's off and we don't feel like ourselves. We just don't know what to do. We go to the doctor and the doctor says, well, your labs are normal, so just deal with it, right? Or go on an antidepressant or just accept that this is your life right now. And that's really saddens me when I get patients that tell me that because there's so much we can do during this time to make your life so much better. And let's explore how we can do that. So let's first talk about some of the main symptoms that women can be feeling, but they're actually dismissing. That is, they're just dealing with it because that's what they're told to deal with. Like, you have no choices. This is just life. So you're feeling exhausted, right? You get up in the morning and you're like, I didn't even sleep last night. How am I supposed to get through today? Brain fog, right? You used to think of words that now you just can't find those words. It starts with the T, 2 syllables, but you can't get it. Very common in perimenopause to have word finding ability difficulty. Weight gain. All of a sudden, your body is kind of going against you. You're gaining weight in areas of your body you've never gained weight before. Low libido. You used to have some desire, but now it's really gone to nothing. Or you may have never had that much desire. Now it's really sub-zero, right? So that's very common again. Mood changes. You get irritable. You snap at people. You snap at your kids. You snap at your coworkers. You're wondering, why am I getting so anxious? Because before I was really could handle things, and now everything seems so overwhelming. And then you're not getting good sleep. You're waking up at 2 or 3 in the morning. Put a little uh, thumbs up in the chat box if that was something, any of these resonate with you. Because the poor sleep, I think, is major because that makes you more irritable, which causes more weight gain, which causes the brain fog. So a lot of these things are kind of like a cyclical thing and a cascade effect, so that if you don't get good sleep, you have a lot of symptoms that are then coming from that. So, what we're going to talk about today is what's happening in your body physiologically as well as emotionally. Okay. And we're going to talk about the truth about hormone therapy, what works and what doesn't work, and what are some of the next steps we can take to make your life even better at this point. So, we need to first clarify about what is perimenopause and what is menopause, because a lot of times these terms get thrown around and people don't clarify what they mean. That's just like a small part of the misinformation that's out there, right? Is the confusion. So we get confused of what is perimenopause. Well, perimenopause is the 2 to 8 years before menopause. Menopause means 1 full year without having a cycle. That means no menstrual period. So it's really the change from reproductive age to a non-reproductive age. And when you look at menopause, it's about the average age is 51 in the United States. Perimenopause is the 2 to 8 years prior to that. Now, some women can go to menopause through menopause at age 45, and some might be 55 or 60. So it can vary, but in general, the average age is 51. So perimenopause is the 2 to 8 years prior to that, where you still have cycles, although they might be getting more irregular. And then you also have the symptoms of hot flashes, night sweats, mood swings, irritability, a lot of things we just saw on that last slide. And that's when your labs can be, quote, normal, but you're feeling that something's totally off. And that's pretty much the perimenopause. Now, that can also happen in your late 30s. So I want to also make sure that people understand that women in their late 30s can also have symptoms. It's not just in your 40s. So if someone says, well, I'm 38, I went to the doctor, I'm having these symptoms, but they said, oh, you're too young to be having those symptoms. Just know that every individual is different and you are unique. So we take your symptoms, we definitely listen to them, and we try to make the best therapy plan, the best plan for you that's personalized and individualized to get your life back on track and back to feeling like yourself. So when we talk about the periods or the cycles, I want to also educate you about what is the menstrual cycle and how this is changing during premenopause, perimenopause, and menopause. Okay. So we look at the 28-day cycle, which is a perfect 28-day cycle that some women have, and some women, it's not 100% every month that they're synchronous. But the first 5 days are the menstrual phase. This is when you're having the bleeding, okay? And then day 1 to 14 is called the follicular phase. That's when the ovary has follicles, and the follicles are being grown, and then one will be chosen as the dominant follicle, and that's the one that gets ovulated. And that's the ovulation phase, which is about day 13 to 14 of the cycle. That's mid-cycle. And
Okay,
then the next 14 days are called the luteal phase. So days 15 to 28. And that's when we see different hormones being made. So the ovary is making different hormones during this time. So I wanted to go over that with you guys so you have at least that foundation. Now let's talk about the hormones that are happening during this time. So you can see on the left is the menstrual cycle, 28-day, and you see that the first part of the cycle, which we call the follicular phase, you can see estrogen is the dominant hormone, right? You also see that at ovulation, which is about day 13, you're going to see, I don't know if my arrow shows, but day 13, or day 14 is ovulation. That's when testosterone also peaks. The reason for that is because Mother Nature wants you to have sex and reproduce during that time. So your egg gets ovulated, it wants to meet the sperm and then be fertilized. So your libido, testosterone, is increased at mid-cycle, and that's for procreation. So it kind of makes sense that Mother Nature did it that way. The other thing you see on this graph to the left is that you can see progesterone in the kind of teal color. It peaks about day 21 or 22 of the cycle. Okay. And that's because it's stabilizing the lining of the uterus. And then you also see that estrogen is also having another peak at that phase. All right. So you're going to see changing hormone levels during the menstrual cycle. So when a woman is having different parts of her cycle, there can be times when PMS symptoms start coming in. That could be the latter part of the luteal phase, but it has to do with hormonal changes. Okay. Now let's look at the graph to the right. This is hormone levels over a woman's lifespan. Okay. So what do you see here? You see a lot of jagged lines, right? But what we want to see is when you look at the reproductive years, you can see that progesterone and estrogen are pretty consistent, that they have their certain cyclical pattern. That is, you're gonna have a spike of estrogen like mid-cycle, you're gonna ovulate, then progesterone is gonna peak about day 21. And you see that going through the reproductive years. Now, let's look at perimenopause. So perimenopause, you can see a lot of the teal line getting less, and that is progesterone. And we'll talk a lot about that in the coming slides. So progesterone tends to drop first, and then you have the estrogen decline. So the different phases of perimenopause, and then you see menopause, where the hormones basically get to very low to zero because your ovaries no longer having the eggs that make the hormones. So why does menopause happen? It's because the ovary runs out of follicles or runs out of eggs. So there's no more eggs to ovulate, and then your hormones drop, and that leads you from a reproductive to a non-reproductive age. So I hope that this explains what happens. And this is a natural transition in every woman's life if she lives to about the age of 51. I mentioned again that it might be earlier, like 30, like 38, 42, something like that, or 55 to 58, but the average age is 51. All right, so now looking at the question and looking at the hormonal roller coaster chart I just said, does it explain something you've been experiencing? Drop a thumbs up sign in the chat if you've ever been told your labs are normal, but you still have felt awful, right? Lots of women have had that happen. So please be interactive and put your reaction. If it's a thumbs up, if you've had that being told to you, your not labs are normal, but you still don't feel like you're quite right. So how do these hormones affect things over time? You can see again here that the teal line is progesterone. So you can see how the progesterone starts really dropping even in the late 30s. We see a drop in progesterone. We're still making a bit of estrogen, but we're not making as much progesterone. And the testosterone line, I want to bring a little attention to there. It's a more of a steady, gradual decline, okay? But it is declining. So our testosterone levels really peak at about age 20, and then they go down continuously till 80, 90, etc. So you can see that like the perimenopause zone kind of like they're like the 40 to 50 one time, and you can see that the hormones are changing. So that's what's causing a lot of these symptoms. So that's the main thing I want you to have from today is that it's your hormones shifting that can cause a lot of these symptoms that impact the brain, your metabolism, your mood, and your sleep, among other things. But those are the main things that they can do. All right. So now, when we look at progesterone, I want to really make this clear that in perimenopause, the progesterone starts dropping before the estrogen does. So that's what's causing the night sweats. That's what's causing the sleep problems. That's causing your irritability. You don't have any patience because you're not getting good sleep. Okay. So when you don't make good sleep, your body can't reset. You also are gaining weight in the midsection because your body's making more cortisol. Cortisol is because you're not sleeping and your body is sensing stress. So when your body is stressed, you make more cortisol. When you make more cortisol, you hold on to fat. So these things all make sense when you understand the hormone component of these changes. And you can see that estrogen decline more slowly. So when you look at early, mid to late perimenopause, because I want to break perimenopause up for you, the early part of perimenopause can be the late 30s and as well into like the mid 40s. And you see that the progesterone is dropping sooner than the estrogen. So mid, you can see, and then in late, really your progesterone is very low and your estrogen's still there, but it's rapidly declining also. So I want to make that point clear because some patients I first start on progesterone therapy to help with some of the symptoms, and then I add estrogen afterwards to help with the symptoms. So what about testosterone? We mentioned about the quiet decline, and we can see here the gradual decline you can see in first off, you can see that peaks about age 20, 25-ish, 20-ish. And then you see a decline, and a steep decline starts happening at age 20, 30, 40 to 50, and then more of a gradual decline after that. But we definitely see testosterone decline. And when I give hormone therapy, I also talk about testosterone therapy because that is something that's needed for libido, muscle mass, and also for energy levels. So I want to make sure we all understand those three hormones that are critical for hormone therapy. So now I want to ask you another question. How long did it take, or has someone, let me go back. How long did it take, or has it taken before someone took your symptoms seriously? Did it only take 6 months, 1 to 2 years, 3+ years, or you're still waiting for someone to actually listen to you and help you with your symptoms? So go ahead and put that in the chat box and we can get kind of a little response about that. Okay. Let me see if I can get to the chat box. Lots of thumbs up, lots of things. Okay, 3+, lots of people. D, no, that's right. Rosemary says, no, I was her GYN and that wouldn't tell me that. So wonderful. And then Teresa said 1 to 2 years. So awesome. Thank you for the interaction, you guys. All right, so moving on. Let's talk about perimenopause even more, and then we'll get into menopause. So it's a stage that where women are often feeling like they should be in the best part of their life, right? But their bodies feel like they're betraying them. So what is this called? This is called the perimenopause paradox. And I actually got the trademark for that because I thought it was a pretty cool little term on words because it is a paradox. Because it's in your 40s to 50s where you have the most, well, some of the wisdom and confidence that you've accrued during this time. You're normally at the height of your career or creativity, but you're having brain fog, fatigue, mood swings, weight changes, all these things. And then you start kind of doubting yourself, saying, wait a minute, I'm not as confident as I used to be. I'm now anxious at times when I shouldn't have been anxious. I feel more overwhelmed about stuff that before was like not that big of a deal. Well, this is definitely perimenopause and menopause symptoms. So here's the paradox. You start having brain fog and memory lapses, mood swings, anxiety, fatigue, hot flashes, night sweats, weight gain, low libido, and disrupted sleep. So I think these symptoms have been said multiple times, and many of you agree with them and have experienced them yourself, right? Me too. Well, let's talk about some of the shifting of the myths. Let's bust some of these myths and what say the facts, okay? So you hear it's just aging. Well, yes, you're aging because the ovary runs out of eggs, but that doesn't mean we can't help the symptoms. So hormonal shifts are measurable. We can see those over time. As I mentioned, those graphs. Now you have those in your brain and you now understand that. But we can treat the symptoms, okay? And that the myth is we'll just push through it. Just deal with it, push through it, right? Many of you have heard that. Well, really, the suffering is optional. I don't believe in suffering. There's no need to suffer when we can offer support, and there's many things we can do to make the symptoms so much better. Then the myth is hormones are dangerous. That was the Women's Health Initiative that came out in 2002. Well, now the science has moved on quite significantly, and now we know that hormones actually can be beneficial. And we know that in November of 2025, there was a movement for the FDA to remove the black box warning on hormone therapy products. Now, they haven't removed it yet, but there's a lot of more science coming through from organizations like the Menopause Society, American College of OBGYN, the Endocrine Society, that are saying that, listen, science has shown that there is no increase in breast cancer and cardiovascular disease. So let's please take that warning off. So the FDA is getting a lot more pressure to do that, but it hasn't yet been removed from the black box warning. So before, how did you feel about hormone therapy? Type one word in the chat: scared, curious, confused, hopeful, skeptical, whatever it was. Go ahead and type that in the chat and let me know what you think about what you've been told. Let's see. Yeah, my doctor was receptive. I was the one who thought I could fight through it. Yeah, a lot of us, and then scared, curious, confused, confident, thanks to me. Ha! Thank you, Rosemary. Confused, absolutely, because there's so much misinformation out there. And even between doctors, you have one that says, oh, you can't be on hormone therapy. You need to be on an antidepressant. Oh, you're too young. You can't be on hormone therapy. Or it causes breast cancer. A lot of things that are unfortunately not true. So let's delve a little deeper into that Women's Health Initiative. It was a study that was done in 2002 that was released. Now, the average age of that population, the women, was 63. Okay. And we know what age is menopause? Average is 51. So these women were about 12 years post menopause. They're on oral synthetic hormone. So they're on synthetic progestin called Provera, and then they're on an oral Premarin, which is Premarin is pregnant mare's urine, which is a type of estrogen. And they had two groups. They had the Premarin only group and the Prem Pro group. So the Premarin only were those women that had a hysterectomy, that were just on estrogen, the Premarin, orally. And then they had Prem Pro, which was the group on Premarin and Provera, synthetic progestin. Okay. Now they found that in the women on Prem Pro had increased risk of breast cancer. Okay, about 26% increased risk. When you looked at the women on Premarin, which is estrogen only, they had less breast cancer than the placebo group. So when they say estrogen causes breast cancer, that's not true. If you even look at the Women's Health Initiative, it says they had less breast cancer than the placebo group. The other thing is when you look at the hormones, it was synthetic progestin that caused the increased risk of breast cancer, not natural progesterone. So we talk about transdermal, we talk about bioidentical hormone therapy, and we personalize this. The other thing is when you look at the cardiovascular disease, 50% of the women in the Women's Health Initiative smoked. You can't take a smoker and a non-smoker and equal them with cardiovascular disease risk. And when they found that when you start hormone therapy within 10 years of the onset of menopause,
Yeah, yeah.
you can actually be cardioprotective. That is, it helps the heart. Now, you can still be on hormone therapy even after 10 years if you do things to make sure that there's no increased risk for heart attack and stroke. So I have some women in their 60s or 70s who say, hey, can I still be on hormones? And I have to just do some special testing on them just to make sure that we're actually not putting them at risk for other things. But many times we can actually help their lives, even if they're, quote, later in life. So now when we look at hormone therapy, we talk about doing it within 10 years of the onset of menopause and even in perimenopause. So start really early. We do transdermal estrogen, bioidentical estradiol and progesterone and testosterone, and we do personalized care. So it's individualized. It's not just cookie cutter, throw this one Prem Pro to every woman in the United States. So I think it shows my passion about that. All right. So what's our approach today? Again, we has evolved not just one oral medication that's Premarin or Prem Pro. We now start earlier. Ideally in perimenopause, we start talking about progesterone, testosterone, and then maybe adding estradiol also. We start with low doses and then use it for a period of time. I get asked, how long can you be on hormone therapy? It's pretty much till you die. We don't know when you're going to die. So basically, you can be on hormone therapy your whole life. And there is a benefit for quality of life with cardiovascular disease, brain health, bone health, etc. So when a doctor says you have to stop after 10 years, don't listen to that doctor. Go to a new doctor that's going to tell you the actual truth about that you can be on for the rest of your life. Now, if something happens to you different that impacts it, yes, we have to take that into account. But in general, most women can be on hormone therapy for the rest of their lives. Transdermal. So with estradiol, we like transdermal therapy. That is a patch or a gel or a cream. And the reason for this, it bypasses the liver. So we don't increase the coagulation factors. In the Women's Health Initiative, the one big risk for women on oral estrogen was DVT or deep venous thrombosis. When you do patches or transdermal, it bypasses the liver and takes that risk out of the equation. And also, a modern approach is personalized to you. It's based on your symptoms, your labs, your history, and puts you in the driver's seat of like what is specifically for you, which is different than your neighbor and your best friend. All right, so what's the truth that hormone therapy can do? It can definitely improve sleep, which then helps decrease cortisol, which then helps with weight. It helps with exercise because you actually can exercise more. It's going to boost your energy so that you feel like you're more energized to actually go through the day. You get better sleep and more energy. You also have better focus because you don't have the brain fog. So you're going to be sharper. You're going to be able to process things like you weren't able to before. And you also want to support metabolism. We're now seeing more and more how menopause and perimenopause can affect the glucose metabolism and insulin resistance. So it actually starts in perimenopause, and that's why to start early is the best to do, but we can definitely still support even if you're menopausal or postmenopausal now. So there's lots of things we can do to make life better. So what are the options for hormones? We have estrogen or estradiol, which is the main one. This is a foundation, helps with sleep, mood, and metabolism. Progesterone is more of a calming hormone. It helps sleep and reduces anxiety. So it takes that edge off of feeling kind of overwhelmed. And then testosterone helps with energy, motivation, muscle strength, and also libido. So there's different delivery options also, so different hormones and different ways we can deliver it. Oral is like a pill, transdermal, a patch, or a gel. There's also vaginal options and injectables. So we have lots of things that we can use in our toolbox. So then I get the question, is it safe? Well, really, it is safe, but it depends on you. And we have to look at your history and your other factors. But basically, women will definitely find benefits, especially in the 40s, 50s, and beyond. That's why I have the site Amazing Over 40. It's amazing over 40, 50, 60, 70, and beyond. Because we start feeling off, but our labs can be normal. We want more energy, sleep, and clarity, and we're willing to be monitored, right? Those are the women that really benefit. But again, it can go into 60s and 70s beyond that. Now, I say here, use caution, consult with your doctor if you had a history of breast cancer. I had a history of breast cancer, and I'm on hormone therapy because I looked at the pros and the cons. And for me, definitely the pros outweighed any of the cons. And that I then did my research and know that estradiol does not cause breast cancer and natural bioidentical progesterone does not cause breast cancer. So you need to have the right doctor to give you those information. Um, if you have a breast cancer, yes, estrogen, there can be receptors on that cancer cell, and it wants to have blood flow, so it's going to have receptors for estrogen and progesterone. But estrogen and progesterone will not mutate the cell. The cell, if it's a cancer cell, it'll feed it, but the hormones do not mutate a normal cell into a cancer cell. So I want to make sure that makes sense for everybody. And if you have a history of DVT or pulmonary embolism, we'll definitely do a transdermal route. History of liver disease or unexplained vaginal bleeding or uncontrolled hypertension, we'll definitely have to find the best route and monitor and adjust over time. And this is where you find a perimenopause menopause specialist that is very familiar with the different routes, the forms, the dosages, etc. So what is my approach? First, I listen. But a lot of doctors, unfortunately, don't listen and they just say, well, this is what you have to do, right? And they don't look at the full picture. And I like to start low and go slow, right? So we use the lowest dose and then we figure out what's the right dose for you. What often goes wrong is that we wait too long to seek help. We accept symptoms as normal, and then we try different things, random supplements without guidance. We just try anything that my friend did this, my sister did that. Let me just try this, right? And I didn't mention in the very beginning, if you stay with me to the end, you're going to get a gift, but I'm sure all of you are going to stay with me, so you get the gift either way. The right approach is listen to the full story. Get the whole picture. Run comprehensive labs so we rule out any thyroid disease or any other reasons why you might be feeling lethargic or having issues. Start low and then adjust thoughtfully and as needed. So this is one of my patients I want to share with you. This is Sharon, and she was came to me at like age 47. She's a VP of a marketing company, and she was really feeling lost. She was fearing that she was going to lose her job because she had memory lapses and she couldn't process like she used to process. So she had severe brain fog. She also started feeling depressed and struggled with poor body image. She had put on a lot of weight and she didn't know how to get the weight off. She tried a lot of non-hormonal supplements, but didn't have any benefit from them. She'd seen multiple doctors, but no one was helping her. So she felt more and more depressed and just basically lacked motivation. Luckily, she came to see me and she actually posted a video online where she said that she was crying in her car. And this is before we even started anything, because I actually had listened to her and said, there's going to be hope that we can do something to make your life better. So what did I do to help Sharon? I first did an initial consultation. I did a full history and I did my wheel of life. And some of my patients know my wheel of life. It's different categories in your life to see like what parts are at doing well and what parts are not doing that well. It's going to be health, business, career, etc., personal growth, finances. But it gives me a good idea of like what's happening in your life from this perspective. I also have a physical wheel of life that looks at like hydration and protein intake and things like that. But we started with that to get kind of an overview of where she was. I then also did a complete hormone testing, and I found that she was consistent with perimenopause, and she was having really bad hot flashes and night sweats. So we started a low dose bioidentical hormone therapy with a patch, estradiol, and progesterone at night. And then we also talked about resetting her lifestyle, which was going to a Mediterranean diet, starting doing weight-bearing exercise, cardio, muscle, weight-bearing exercise to build more muscle, stress reduction, and sleep hygiene. All of these were really important to get her back to be reset into how she wanted to live her life. So this is Sharon now, the new Sharon. So you can see she's lost like over 80 pounds. She feels confident and clear at her work. She's more motivated and energized. She now knows she can do her job and she feels confident in her job. She's elated with her weight loss. Her hormones are balanced, and now she's finally sleeping through the night and enjoying her life. What a concept, right? Amazing. So you're not crazy, you're changing, your hormones are changing, and you can feel amazing. Again, why my site's called Amazing Over 40. So you don't have to guess anymore. Let's figure this out together. Here's a way that you can go to my website, get an appointment if you need an appointment. I'm happy to help you. Also, if you got friends or neighbors, family that need help, please send them my way. Have them look at this webinar. Feel free to contact me. There's the different ways you can contact me. You can have my email, telephone. I have the website, lots of blogs, lots of webinars, videos that I have. And I also have a great diva group. So all of you that want to be divas with me, come to my diva group and we have fun times. We do different things and I have special webinars for you and stuff. So it's fun to be part of that certain group. It's a Facebook diva group. And here's the gift you're going to get. You're going to get my hormone therapy guide, and it's going to go over all the things I covered today. It's available. You're going to get, if you signed up for this webinar, you'll get an email with the link to download it. And you'll also get a link to get the recording for this webinar in case you couldn't be here at this time to listen. So get your gift and claim it. And then also, if you want to share it with some of your friends, you can. But this is a gift for you because you stayed on here with me today and help me give your feedback and tell me about what your menopause, perimenopause kind of challenges were. So with that, I'm going to now open it up to questions and I will answer whatever question and answers you guys have. So if you want to put something in the chat box, let me know. I do have a question here from Mary. Um, how often do you recommend having blood work done? Great question. It really depends where you are and what's happening. Initially, I do get a comprehensive panel on, I do my Well Woman panel with hormones, which looks at your cholesterol, your CBC, your comprehensive metabolic panel, your thyroid function, everything, so that we can basically see where you are and what things we need to fill in, right? But then once you're on hormone therapy, it can be every 6 months, it could be annually. I have some women who get their blood work done and then they're on a similar dose for quite some time, and we don't necessarily have to check blood work that frequently if we're talking about hormones. I still like the lipids and all that checked annually. And sometimes when I do that annually, I will add estradiol, progesterone, and testosterone, free and total testosterone to that. So it depends where you are with regard to what phase you're in and what we're doing. So it I guess it's individual, but in general, every year. But if we're actually looking at to see if you're having symptoms and stuff, it might be 3 to 6 months. So again, question. How long can we stay on hormone replacement therapy? Great question. I think I mentioned that in the presentation, but in case you missed it, or because I was going pretty fast through things, you can always review this presentation. That's why it's recorded. So go back, memorize that menstrual cycle, memorize everything else I did, right? But basically, you can stay on it through the rest of your life. You do not need to stop. If a doctor says you have to stop after 5 to 10 years, find a new doctor because that doctor doesn't know the research. So you can be on for the rest of your life assuming there's no other complication that's causing an issue, right? With estrogen alone, same question. Can we stay on it forever? Yes. And Rosemary, thank you for bringing that question up because sometimes I get the question, well, if I'm on estrogen only, do I need to be on progesterone? A lot of times we use progesterone to help protect the uterus. Okay. So if you've had a hysterectomy okay, and you no longer have a uterus, you do not have to be on progesterone. You can be on estrogen alone. Okay. Now, there are some women who had a hysterectomy that I do give progesterone to because it helps with sleep and it helps with mood. So, basically, sorry, I got lost my train of thought because they changed the viewpoint of this. So if you had a hysterectomy, you don't have to be on progesterone, but I do give progesterone because it can help with certain symptoms. Okay. Now, Rosemary brings up the question, can she take progesterone alone? Yes, you can. Absolutely. And you can stay on it forever. And the progesterone is going to be more calming, kind of like helps with sleep, night sweats, etc. So yes, you can be on progesterone alone. If you've had a hysterectomy, you can be on estrogen only. If you have a uterus, you want to make sure that you're on estrogen and progesterone, unless you also are having something else that's protecting the uterus, like a progesterone only IUD, etc. Nancy, I'm 75 and I'm on compounding cream for 20 years. Compounding cream is great. I think that I love that compounding cream. It can make it exactly for you. There's a lot more doses available now in the patches, etc. So if you're doing well with the compounding pharmacy, you don't worry about it. You just stick with your ad. So that's a great question. Um, Now, testosterone is not normally in a regular like commercial pharmacy. Testosterone is going to be a compounded because they don't make testosterone for women at CVS and Walgreens. So I like to do a compounded testosterone, and I can really start low and then go up as we need to. Um, Now, I started to take hormones, but I stopped taking them because breast tenderness. I had breast tenderness. So basically, that means probably on too much estrogen, and we need to ch change the estrogen dose a little bit because we can get that breast tenderness out of the equation. So it might just be we need to tighter that to estrogen just a little lower so we get rid of the breast tenderness. Which do we avoid with the history of PE and TAH with ovarian cancer diagnosis? Okay. If you had a history of pulmonary embolism, we want to definitely not do oral estrogen. Sorry, no oral estrogen because that increases the risk of blood clot, DVT, not pulmonary embolism, because it goes to the liver and makes the coagulation factors, increases clotting. So definitely you could do a low dose transdermal if you had a history of DVT or PE. Now, TAH means probably a total abdominal hysterectomy. So if you had that with ovarian cancer and had a hysterectomy, you could still be on hormone therapy. And you may only need to be on estrogen only because you had a hysterectomy. So these are really good questions. You guys are tough. Really good questions. Let me see. There was one about here that I had in the beginning. I thought I needed, my mom had breast cancer. Yeah. So a family history of breast cancer, does that make you a contraindication to hormone therapy? No. You can still be on hormone therapy. You need to be monitored with mammograms and possibly MRIs if you need them, but does not mean you cannot take hormone therapy. I had breast cancer stage 1. My doctor oncologist wanted to get me off the hormones, say you have to stop and be on an aromatase inhibitor. I had really bad brain fog. I couldn't think. And I was really devastated because this was in, oh my God, 2018. And I almost was like in tears because I couldn't practice because I couldn't think. My brain fog was so bad. I did my research and I realized no, I could be on hormones because it does not cause breast cancer. It's if you have a cancer cell, it'll feed a cancer cell, but hormone therapy does not mutate a normal cell into a cancer cell. What causes the mutations are hormone disruptors. Those are things in our environment like pesticides, uh, oh my God, things in our water system, things that we're exposed to with chemicals in the air that cause mutation in our cells. So it's not hormone therapy that causes breast cancer. There's a great book, Estrogen Matters. So thank you for bringing that up, everyone. Estrogen Matters, great book by Blooming, talks all about hormone therapy and the risk of breast cancer and cardiovascular disease. So I recommend that for anybody who wants to read it. Also, go to my blogs because they will talk about the myths and benefits of hormone therapy too. Does testosterone help with sleep and weight gain too? Testosterone normally is used for libido, energy, and muscle mass. It doesn't really help with sleep. So if you want it to maybe get a little more, and you can do that, Rosemary, if you want a little testosterone, but we don't want acne, hair growth, or aggression. So we start really low and we would do it in the morning. So it's not at nighttime. We do it in the morning to help with energy. Okay, a friend of mine is using estrogen patch and using a vaginal cream. Okay, is this individual or should they both be used? Great question. You guys are on it. I'm so happy. Most women need an additional vaginal estrogen in addition to systemic estrogen. Some women do not. Some women get enough of estrogen through their patch or their gel or their cream or their oral pill. Okay. But most women need an additional estrogen for the vaginal tissues. That'll help the pelvic floor. It'll help the bladder, the urethra, and the vaginal tissues so that they stay moisturized, so that sex doesn't hurt, right? So that you can have an estrogen patch and a vaginal cream. So it's very common to need both. There are some women who are only on vaginal cream itself, which is a just for the vaginal tissues, and they do not need to be on progesterone because their uterus is not going to be at risk for any systemic estrogen. So that's why you need to go to a specialist because there's so many things that are so confusing that you need to have the right answers because people throw things around that are really difficult when one person says this and one person says that, and then you get completely confused. So these are really, really amazing questions. I want to thank everyone. Let me see if there's any other questions. Jessica, I wish I'd met you 7 years ago. Yes, I know. A lot of my patients say, why didn't I find you in my late 30s or early 40s? Well, the good news is you found me now, which is what's important, and that we can help women and women who are whatever age. Please, I had one woman, she was in her 70s and she was miserable. She couldn't sleep at night. She had hot flashes and night sweats. I then did a coronary calcium score for her, which is a test to look at the cardiovascular disease. And she had a coronary calcium score of 0, which means no risk of clot or plaque in the arteries. She is now thriving, so happy. And she's like, oh my God, I got my life back, right? And that's music to my ears because when I hear that, it's like, that's why I do this. This is why I have these webinars. Please send people to my website. They can, because I think I post this on the website so that everyone has access to this. And I think I covered all the questions and we did it in 45 minutes, which was phenomenal. And I want to thank everyone who's stayed on. You're going to get your gifts in the email, so please check your email. I'll also have a recording, so if you want to share that with your friends and family, please do. And in respect for all your time, I want to thank you so much for joining me and everyone, Jasna, Leah, Rosemary, Jessica, and everyone I missed, Teresa, etc. Everyone who joined me, thank you so much. And I look forward to seeing you next time. All right, till then, remember, stay amazing. Bye bye.